Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
We resume this second episode of this special 2-episode series on breast screening with Associate Professor Michelle Reintals, who is an Australian radiologist who has specialised in breast imaging and is the Clinical Director of BreastScreen South Australia. Thank you again for joining us, Michelle.
Thank you. Thank you, Steve and Travis.
Michelle, there is research, of which BreastScreen SA has been involved in, showing that breast density is an important factor in breast cancer. What is the importance of breast density?
So breast density is not new to us. It is a mammographic term, so it should theoretically be called mammographic breast density. It doesn't relate to the look or the feel or touch of the breast. It is something that you can only determine from a mammogram. And the terminology has been around since the late 1970s when John Wolfe first discussed it. And since then, Norman Boyd has also done some further research. And as we know, it's very topical. It has become a discussion internationally over the last 1 to 2 decades. And there are now various methods and software technologies available in which one can actually measure mammographic breast density. So we know it's important for several reasons. Probably first and foremost that it is a risk factor for breast cancer. And the irony is that the higher your breast density, the higher your risk for breast cancer. But then, unfortunately, it means the sensitivity of your mammogram is then lower. So breast tissue itself is white on a mammogram, and breast cancers are typically white on a mammogram. So naturally, the more white you have, the harder it is to see the cancer on there. I still come back to the fact that who is reading your mammogram is a very key part of the sensitivity of a mammogram. And there are a lot of studies out there that refer to the sensitivity and specificity. So, meaning the likelihood of detecting a breast cancer. And then the specificity refers to if you see an abnormality, what's the likelihood it's going to be a cancer? They certainly show that sensitivity and specificity reduce once your breast density goes up. But there are other technologies out there that do better than mammography. But at the moment, what they're trying to work out, not just nationally, but internationally, is what are the best alternatives that are available or that can be incorporated, and keeping in mind that screening programs are about currently a one-size-fits-all for the population. And the more we learn, and as I mentioned in the previous session, it's a really exciting time to be part of breast imaging. And, there's a lot of consumer advocacy groups out there that are contributing to this movement. But what we're seeing is a potential shift to more of a personalised screening model. And you'll be talking with Kelly-Anne Phillips about iPrevent, and that's a risk-based model that's out there. There are other models available as well. There are the genetic profiling that you can do on clients with SNPs that also speak to risk. There are obviously the family history indicators that are risk factors. There's breast density, which is a risk factor. So it's a big soup at the moment, and breast density is one ingredient to that soup. it's going to take a lot of very intelligent people around a table and, internationally to work out exactly how to work through all of that.
What are the classifications for breast density and the implications for the patient?
Yeah, so currently there are 4 classifications or categories for breast density. There's A, B, C, and D. So A refers to fibrofatty. It's your lowest breast density on a mammogram. B refers to scattered, so it refers to the scattered fibroglandular tissue. And that's more your normal risk, whereas A is actually lower than normal risk. Then you have C, which refers to heterogeneous. So that's about the distribution of the breast tissue being heterogeneous throughout the breast. And that's higher than normal risk. And then there's BI-RADS D, which is what we refer to as extreme breast density. That is the highest breast density category and therefore has the highest risk associated with it. There have been studies done that show the increased risk. Certainly back when Norman Boyd did the studies, they talked about a 4 to 6-fold increased risk. But there have been, further studies that have occurred since then, and they really characterise high breast density, so the D category, compared to the normal risk, which is B, as being 2-fold increase. So we do know, as I mentioned, there are so many other risk factors that need to be put into that soup to sort of balance that out. They can't be looked at in isolation. And we're now very fortunate here in South Australia to have rolled out breast density reporting across our fleet of screening mammograms. And so all women now receive their breast density category, whether it be A, B, C or D, and that they get that in their letter, and their GP also gets their results as well, or if they nominate a GP. And then there's a little paragraph that explains how many women in the population have that breast density category. And we also have a very robust website for BreastScreen SA where women can actually go and research the information a little bit more. We have bespoke videos available that they can click on and see what it means, if they receive a letter that they're BI-RADS A versus BI-RADS D. And then we have frequently asked questions, and we also have a professional fact sheet as well. So we've tried to cover all bases, I suppose, with questions, but no doubt there's always more questions to be had.
Just on the reporting, there was issues in the literature about providing that information could create undue stress in patients and providing that. Was that a consideration for BreastScreen South Australia?
Yeah, certainly. So before we rolled out statewide reporting, we actually spent a good 3 years putting together a research pilot study. It finally occurred, thanks to COVID delaying everything, in 2020, and it occurred over a 6-month period, and we chose 3 specific screening sites. So there were 2 fixed and 1 mobile unit that were chosen, and we chose it according to demographics and culture, so we could get a broad range of the community. And what we found was there were about 15,000 women that actually had their screening mammogram during that 6-month period at those 3 locations. The vast majority were of Australian and European descent, with a smaller proportion of Asian and Indigenous called communities. And a third of those women responded via a survey that we sent out to all of the participants. And that survey was a psychosocial analysis of the impact on reporting of breast density within the population. And so it really comes back to, we wanted to make sure that before we rolled it out statewide, that we weren't in fact harming women. So we know from the consumer advocates that women are wanting their breast density reported on, that it is their right to know, and given it's only available on a mammogram, it therefore has to come from those that are reporting the mammogram. And so the outcome of that survey was that approximately 35% responded, and of those that responded, it was quite significant that they didn't feel more anxious. Those that did feel more anxious tended to be in the BI-RADS D category group. And that's completely understandable because we've just told them you're at increased risk and we're less likely to pick up your cancer. So are you feeling anxious? So I'm surprised that those numbers weren't higher, but I think that probably what it speaks to is that the information and the education that we provided allowed for, enough information for them to understand the ramifications of breast density, and that it is an evolving area and no one has all of the answers and at this stage, but it is still their right to know what their breast density is. So I was very pleased to see the results that came through.
Michelle, I'm just poised to read a book by an academic who is arguing that anxiety in evolutionary terms has actually been one of the most helpful things that we've evolved to have, although out of control with in the current world, thanks to media and all those sorts of things. But in this case, I wonder if there's a silver lining that the women, particularly with the D classification, might have that anxiety as a catalyst to maintain vigilance on the journey, working with their GPs and those around them.
Look, it may well turn out to be that. I suppose in my years in private practice, I would traditionally see every woman and tell her the result of her mammogram and explain her breast density when, we obviously had Volpara was the automated system where I worked, both in South Australia and Queensland. And I have to say that the anxiety levels are quite variable amongst women. And when you see a woman who is highly anxious, in tears, and desperate to not have high breast density and be of increased risk, and we don't know their circumstances. They could be single mums with, young teenage kids and the sole provider, and they're thinking if they're not around because they get breast cancer, what's the impact on their children? They may have had a dear friend die of breast cancer and they're reliving that memory, or a parent. So we don't fundamentally know the cause for anxiety. I think, with COVID, we've seen anxiety bubble to the surface just for normal situations, leave alone being told, you're at twofold increased risk of breast cancer. So I'm a bit hesitant to say that anxiety is a good thing. I think a low level of anxiety is because it motivates you, but not a high level. And I've seen some women just in tears and they go back to their GP and their GP then refers them every year for a mammogram. And that's not the right thing either. If you can't see the cancer in the first place, why do another mammogram? So, I think the consumers themselves are driving a lot of the referral base with that, which I think is something to be very cautious about. I think it needs to still be medically based.
With the higher risk categories, so we're talking about C and D, will that change? Let's just say in that isolation, they don't have a strong family history, but they're C and D, they have high breast density. Will that change their risk categorization for a higher risk and have annual screening, or will it still be 2 yearly screening mammography recommended? We just know the density, they have a higher risk.
Yeah, I think that area is evolving and we're not there yet. There's a lot of research occurring nationally and internationally. We do know that the Commonwealth has funded a big project called ROSA, so Roadmap for Optimised Screening, and that's been led by Carolyn Nixon from the University of Melbourne and Bruce Mann, a surgeon from Melbourne. It's been a huge collaborative effort, and I've been very fortunate to be part of that as well. There's another research project called MyBrisk, which also I'm fortunate to be part of. John Hopper, who's a researcher, is the principal investigator for that. And that's incorporating AI and genetics and, using large data sets, etc. So there's a lot of work occurring in that space. I think it's premature to say what we will do in time to come. At the moment, no, we're not offering annual screening for women with high breast density for the reason that if you can't see it in the first place on the mammogram, why doing it more regularly would help. It's more about potentially alternative imaging for those women. We do know from EUSOBI, so the European Society for Breast Imaging, that they've come out with a very bold set of guidelines a year ago where they recommended MRI for women with high breast density, and that hasn't been implemented even in their own country yet because it's obviously such an impacting position statement, and they're still undergoing further research in that area. But it is absolutely food for thought, and potentially the way that various nations may go, but there are massive implications for all of a sudden transitioning 40 to 50% of the community from mammography across to MRI, not least of which is the massive cost. But an MRI is an invasive procedure. You require an injection of gadolinium, have to go within a magnet. There are some patients that can't have the gadolinium because they've got renal function issues, or they may have metallic implants which are contraindicated to have an MRI. It's not accessible to regional and remote women, and the whole point of population screening is to make it equity of access for everyone. So there's a lot of discussion occurring, and whilst we'd all like to know where it will end up, it's too early as yet. And I wouldn't like to see that women start to self-refer for various investigations when we actually know what the evidence and the proof is. There are various other techniques out there. There's contrast-enhanced mammography, there's tomosynthesis, there's ultrasound. They all have variable cancer detection rates, but we do know that screening mammography works for the general population, and the more you add to the imaging that you do, the more cancers you'll find. But then you start to get into that realm of, well, then we start biopsying more lesions, we start to cause more anxiety and harm. We might cause unnecessary operations. It's a bigger picture issue.
Can breast density change at all, or is your category your category?
No, absolutely. So for a small percentage of women, they remain in their category for life in the high breast density. It's sort of a genetic makeup of their breast tissue. But for the vast majority of women, it's hormonally based. And, you take away that estrogen during menopause and the breast density reduces. Similarly, if you put a woman on HRT perimenopausally, their breast density goes back up. So for that reason, there's also research occurring in the space of putting women on tamoxifen as a means to reduce breast density, and work's being done here in Australia and overseas as well, which has shown that it certainly has been a risk reduction with breast density as well.
And we're just touching on the personalised breast screening area. Is this something that BreastScreen's sort of trending towards as well? Are you incorporating that kind of approach?
Yeah, BreastScreen is by definition population-based, and we do try and incorporate the nuances to women's individual risk. The fact that we're now starting to measure breast density here in SA and WA the same means that we're already starting to open the field for learning more and doing more research in that space. Based on the genetics and the discussion that we had in the last session, we do modify our screening intervals according to certain risk profiles. We do certainly advocate that women undergo risk profiling, which they can do via their breast specialist, or they can go on the iPrevent or IBIS tool and identify what their risk is, and then go and have a chat with their breast specialist. But I think with regards to personalised risk-based modelling, I mentioned the ROSA project and also the MyBreast project. They're actually aimed at looking into those areas, and rather than making it a population one-size-fits-all, looking at a risk-based model. So we are making steps into that realm already here in Australia, which is just, so exciting. And every year we learn something new.
I fully understand what you meant earlier about this being an exciting time to be involved in this particular field. But perhaps in closing, Michelle, are there any final thoughts you might have about the future direction of BreastScreen for GPs?
I have a girlfriend who's a GP here in Adelaide, and she contacted me recently and said, what do I do with a patient who's in BI-RADS D category? And I thought, it's just such a common question and a discussion that we all have. And it was a situation where the result of that discussion just wasn't pleasing, the outcome of it. It's not as if you can say, okay, go and have an MRI, because it depends on whether the patient can afford it. And we will see in the next 5 to 10 years some massive changes. And I think the advocacy that's occurring around the nation by the consumers is so important. But I think also that clinical information that we're gathering and garnering is all part of that. And the GPs are, without question, a very important part of understanding a woman's risk, as is her breast specialist, of course. And I think that the GP should continue to just ask that question, what should I do? And I think that, they should also advocate for the changes that will come ahead and be part of that discussion. I know that certainly MyBrisk and other research entities that are going on at the moment are also looking at AI, so artificial intelligence. And Travis, I think you probably know more about it than I do with regards to the AI in the pathology space, but in the radiology space, it's a potential goldmine to improve cancer detection. And, maybe we don't need to be changing our different modelling. Maybe we just need to be looking at AI. So time will tell, but I would just encourage the GPs to be faithful to what they know and to keep asking the questions of their colleagues and to support their clients who are in the higher breast density category, but knowing that we don't have all the answers yet and we can't put the cart before the horse, I think is probably the biggest, not most useful sentence, but probably the most important sentence to make.
On that note, Associate Professor Michelle Reintals, thank you for being part of This Medical Life.
Pleasure. Thank you very much for having me. Much appreciated.
Professor Kelly-Anne Phillips is a medical oncologist and researcher at the Peter MacCallum Cancer Centre. As a highly productive clinician researcher, she treats women affected with breast cancer and runs a prevention clinic for those at high risk, while concurrently leading internationally recognised research related to breast cancer genetics and treatment. Her research and related health policy advocacy have led to better and more socially equitable breast cancer treatment and prevention options for Australian women. She has authored over 240 peer-reviewed publications and is also recognised as an effective mentor of junior clinician researchers. Professor Kelly-Anne Phillips is our guest today on This Medical Life podcast. Welcome.
Thank you so much. Great to be here.
Kelly-Anne, in 2019, you published a breast cancer risk assessment tool called iPrevent. Could you just explain for us what is iPrevent and how was it developed?
Yes, so iPrevent is a free, evidence-based online tool that was developed really to help women to understand their own personal breast cancer risk, but perhaps more importantly also to know how to act on that risk should they choose to, in collaboration with their clinicians. So it's actually an RACGP accepted clinical resource, and it's signposted now by many peak cancer organisations, including Cancer Australia, BreastScreen, cancer councils, and it's also endorsed in national FAQ guidelines for breast cancer risk assessment and management. In terms of its development, I led the development of the tool, but it was very much a multidisciplinary team effort. So, the development team included consumers, a computer scientist, obviously, epidemiologists, breast surgeons, GPs, geneticists, and we even had a sociologist on the team who actually was very important in the early development phase.
So we're looking at this program and it uses an algorithm to assess risk for developing breast cancer over a 10-year period. But there are two models mentioned. One's IBIS and is it Bodacia? Can you tell us what are these?
Yes, I think it's pronounced Bodacia.
Oh, there we go.
Understand your Greek mythology or something for that. So these are really data-driven mathematical models that were developed to help estimate breast cancer risk. So IBIS is also known as the Tyrer-Cuzick model, and Bodacia is now known as the CAN risk model. Both of these were developed by epidemiologists in the UK. So IBIS developed by Professor Jack Cuzick and Bodacia by Professor Antonis Antonou. And they in fact, importantly, both of those people were part of the iPrevent development team. So both of these risk estimation models have actually been freely available online for quite some time. But the problem was that although they're able to accurately estimate a woman's risk, they didn't go that next, what I think is a vital step, which is helping women and their clinicians, once they know their risk, to work out what they should do about it. So we developed iPrevent specifically to try and fill that gap. Because we'd previously done research led by my sociologist colleague that I mentioned, Louise Keogh at the University of Melbourne. And what that research demonstrated with women was quite clearly that women wanted to know their breast cancer risk, but only if they were informed about what they could do about it. So they didn't want to hear their risk and just have it hanging. They wanted to hear their risk and know what the actions were, which obviously makes sense. So linking those downstream risk management strategies or actions, we thought was critical to this online tool.
Now, so this is an online assessment risk tool for doctors and patients. Can you just tell us, just take us right back to the step, how long does this is a survey take, or and what kind of information needs to be put into it to give a good risk assessment?
Yeah, so how long it takes is a little bit dependent on the initial responses of the woman. So, for example, family history of cancer is obviously an important component of risk assessment. So that's an important part of the tool, and there are several questions on that. But a woman who has a big family with a lot of cancer will see more questions than a woman who has a smaller family with not much cancer. So the sorts of information that needs to go in are things like essentially all the risk factors for breast cancer. So family history, we've mentioned, some of the reproductive risk factors, some of the lifestyle risk factors. At the moment, iPrevent does not include breast density. There isn't the ability to incorporate that currently. Whereas the most recent versions of the two underlying algorithms that we were talking about, IBIS and Bodacia, do include breast density. We're currently in the process of updating iPrevent so that women or clinicians will be able to input that data.
So when someone's doing it, is this something that a patient does by themselves, or is this something in conjunction with a clinician, or would a clinician do it for them?
Any of those options are possible. So, when we first conceived of this idea, we were very much thinking about a tool that would be used by clinicians. But interestingly, we changed our mind during the development process because we had very strong feedback from consumers that they wanted to be able to use it directly without necessarily needing to have a doctor in the middle of it. So it's now really designed for use in any of those ways, but women are advised to discuss the results with their doctor.
So when someone goes through either with their clinician or by themselves, how are the results presented? Well, what do the results mean for patients who go into iPrevent and try this survey?
Yes. So in terms of the risk estimate result, we present that in sort of a stepwise fashion. So initially, the woman would just see a sort of a qualitative description of her risk. So that might be, your risk is about average compared to other women your age, or it might be your risk is substantially increased compared to other women your age. So it's kind of a qualitative risk estimate. And then we kind of deliberately make women pause and think about whether they want more detailed information than that. So they can choose to click into more detailed information, but there is a warning at that point that some women might find that detailed information uncomfortable. But if they do choose to click into the more detailed information, then I guess the first thing to say is that importantly, we don't present relative risks of breast cancer. We present absolute risks, which is obviously much more important to the individual woman. And we present both residual lifetime risks to age 80, so from the current age until the woman turns 80, and we present a shorter term risk, which is the 10-year risk. Now, in terms of how we actually present the risk, we know that different people like to receive numerical information in different ways. So we actually offer 3 different ways of seeing the risk. Initially, there's just a sentence with the percentage risk described, but the woman also has the opportunity to click into a pictogram, which we actually know is often the most effective format for risk communication with consumers. And then there's also the option of looking at a graph, which we find the doctors quite like the graphs. So that's the risk estimation information. But as I said, the important thing about iPrevent is we also provide the information about what can be done about that risk. And so depending on the woman's risk level, she'll see a menu that will have different options that she can click into. So for every woman on that menu, lifestyle and screening will be on the menu and able to be clicked into. For women who are at increased risk, they'll also see medications to reduce risk on that menu. And for women who are at very high risk, they'll see risk-reducing surgery on that menu. And women can choose to click into, get more information on any of those things that they're interested in. And I think another thing that is important about iPrevent is that the risk reduction or risk management option information is not just generic either. It's actually very tailored to the woman depending on her age and her risk level. And we provide information about the absolute risk reductions that she might see with things like medications or surgery, for example.
Kelly-Anne, I know Travis wants to go a little deeper into that, but before we go further, at that juncture where a woman has been given the general outline of her risk, do you know what percentage actually click through to the advanced next stage to learn more versus those who stop at just that general bit of information?
Yes, that's an interesting question. We don't have those data. So at the moment, we're really just collecting the number of hits onto iPrevent. We don't collect any detailed data. And I guess that's another thing to point out, and it's actually pointed out on the landing page for iPrevent. We don't collect any of the data that women enter. So as soon as you log out of iPrevent, that data's gone.
Now, from the medical perspective, what categories of risk are we talking about? So I gather that population level is baseline, and then you have moderate and high risk. What does that risk mean? What does moderate risk mean for the patient? What does high risk mean for the patient?
Yes. So we use the Cancer Australia and RACGP sort of classification of risk because obviously those words moderate and high mean different things to different people, which I think is what you're asking. But in iPrevent, moderate risk means between 1.5 and 3 times the population risk. and high risk is greater than 3 times. So, as I said, that's consistent with the way Cancer Australia categorises risk. And it's not too dissimilar from how NICE in the UK and other groups internationally categorise risk.
So if we're looking at patients who have moderate risk, are in the moderate risk category, what are the risk-reducing options that are mentioned for these patients?
Yes, so a moderate risk woman on her menu would see lifestyle factors as a way of potentially reducing her risk. She would see medications on the menu, and she wouldn't see information on risk-reducing surgery, because generally that's not considered to be appropriate for women at just a moderate level of risk. She would also see screening on her list, although, of course, screening is not a risk reduction option. It doesn't reduce breast cancer risk, but it is a way of potentially managing risk.
You've mentioned it a few times, and I'm interested. What lifestyle factors are we talking about to modify the breast cancer risk in patients?
Yes, so I think the key ones are minimising alcohol intake, increasing physical activity, and maintaining a healthy body weight are kind of the key ones. And women have input that information about themselves into iPrevent, so we kind of feed that back to them in the lifestyle section. So if they're drinking 20 standard drinks of alcohol a week, we highlight that that might be something that they want to focus on, for example. So again, even that lifestyle information is somewhat personalised.
Can I ask what's considered high risk and low risk in alcohol intake?
That's actually quite a controversial question. So, there are different guidelines, and there are different views on how appropriate some of those guidelines are. I will say that the data suggests that any level of alcohol intake increases risk, actually. So the safest way to minimise your risk for breast cancer and a lot of other diseases is, to really, really minimise your alcohol intake. For the purposes of iPrevent, we use the guidance from Cancer Australia.
I'll just interject. Travis asked that because he's a teetotal and I'm not.
There you go. Well,
Now, looking at the high-risk patients, they obviously get a different slate of options. And is this the warning that comes up for patients? Because this clearly goes into the preventative surgery area.
That's right. So it does go into preventative surgery. So women would not, it doesn't just flash up on the screen unexpectedly. Women would know that they were clicking on that thing in the menu, and that's the information they're about to see. I guess it can be confronting for some women. An online tool is never going to be able to beat the communication style of a one-on-one consult with a sensitive clinician. But as I say, we have tried to make women think before they click on these options and see the information.
So the surgery we're talking about is mastectomies and the Selping oophorectomy. Looking at the later one there, so removal of ovary and stuff, is this bordering on people who have BRCA mutations as well?
The tool it's really focused on breast cancer risk reduction. So the surgical option is really focused on bilateral mastectomy, which is usually done, as you know, with a reconstruction. We ask a question about bilateral Selping oophorectomy because there is some evidence that may help reduce breast cancer risk. Although in BRCA1 and 2 mutation carriers, that is becoming less clear. We don't advise Selping oophorectomy specifically as a method of reducing breast cancer risk in the tool. Yeah, so it's mainly focused on bilateral mastectomy.
Okay. And with iPrevent, this is stated as being a 10-year risk for women taken up until the age of 80. So does this mean that it's sort of recommendations that this is revisited each 10 years?
Yes, well, I think that I actually think we need a much broader conversation about, risk assessment in Australia and how we go about it, because obviously, breast cancer is a major public health issue. And, as we've just been talking about, we've got really effective ways of reducing risk and preventing many of these breast cancers. But what we know at the moment is that most women, it's women themselves who are initiating a conversation with their clinicians about risk rather than necessarily the other way around. And, my view is that we should be moving towards a system where we have systematic and routine risk assessment and tailored risk management advice for all women in the community. And yes, that would need to be repeated at regular intervals because obviously risk factors change and that can dramatically affect your risk estimate. So, I think there's some work to be done around, the health economic modelling and so forth of that sort of an approach. But at the moment, what we say in iPrevent is, if any of your risk factors change, please go through and do the iPrevent tool again because your risk assessment might change.
I've just got one more question just before we wrap things up with Steve. Have you had any feedback from either doctors or patients about iPrevent and just the interactions with it?
Well, we did do some formal usability and acceptability testing, which with both women and clinicians, which we published in 2018. And, it was felt to be very acceptable and quite usable. Actually, on the basis of that research, we sort of rejigged the way we answered some of the family history questions. Apart from that, we do have sort of ad hoc women and clinicians sort of write into us ad hoc with communications about iPrevent, but we haven't done any further formal assessments since we've launched it.
Do you have any further thoughts or advice, perhaps for our general practitioners listening in, regarding iPrevent?
Well, I'm really hoping that GPs will find iPrevent helpful for their practice. I'm honestly in awe of GPs and the really diverse subject matter that they have to be across every day. I think that's probably why I decided to be a specialist and not a GP. But I'm really hoping that iPrevent will take some of that burden off GPs because it really provides, the content knowledge in this area of breast cancer risk assessment and risk management. So I really just encourage GPs to get online and have a look at it and see if it could be useful in their practices and also to have a think about, whether the nurses within the GP practices could be assisting with this risk assessment component.
The final thought is there's also iPrevent is freely available at Peter Mac online. We'll have some links into our show notes for that as well, so that people can easily get access to it as well.
Professor Kelly-Anne Phillips, thank you for joining This Medical Life.
Great, thank you so much.
Dr. Sandy Minck is a Fellow of the Royal Australian College of GPs with 10 years of clinical practice and over 20 years of medical education and communications experience. Sandy's an advocate for breast density awareness and notification and personalised breast cancer risk assessment. She's passionate about patient empowerment and informed, shared decision-making. Sandy's advocacy arose from the lived experience in finding out that she was at high risk for breast cancer and the challenges and overwhelming process of obtaining the information needed to make the best decisions for her situation. Sandy's a consumer representative and associate investigator on several research grant proposals studying breast density and personalised breast cancer risk assessment. Dr. Sandy Minck, welcome to This Medical Life.
Thank you for having me. It's a pleasure to be here.
Sandy, can you tell us about your personal family history dealing with breast cancer?
Sure. So my mother was diagnosed with breast cancer at age 57 after a routine mammogram. She had surgery, chemo, radiation, the works. She got to the 5-year mark expecting to receive the all clear, but unfortunately her tumour markers were elevated and she was found to have metastatic disease. And she passed away at age 69 from metastatic breast cancer. On my father's side, I have an aunt who had DCIS breast cancer at age 63, but she survived that into her 90s. So my personal history is I've always had complex breasts, and I had a couple of benign lesions that were followed annually. I was told I had dense breasts in 2019, but I really did not understand the implications of that. So I was kind of blissfully oblivious, but was having annual mammograms and ultrasound. So I was in good hands. I was lucky, fortunate. In June last year, my mammogram showed some microcalcification. So I had a vacuum-assisted biopsy, mammogram guided, which took some time, required 3 goes to get the area. That found atypical lobular hyperplasia as an incidental finding. So I went and saw a breast surgeon to discuss what to do about this. Despite being classified as high risk, and we'll talk more about that later, I didn't qualify for an MRI at that time because of my age. There was a cutoff of less than 50. I was 56. That age cutoff has actually subsequently increased to 60, which is great. So I paid $700 for an MRI, and I'm grateful I did because that showed an area suspicious of DCIS in the region where I'd had the biopsy. So I had a wide local excision, and that showed more atypical lobular hyperplasia, lobular carcinoma in situ, and that's also now referred to as lobular neoplasia. So LCIS is not considered stage 0 cancer in the same way DCIS is, but it does increase your risk by about up to 10 times.
Sandy, I have to interject. This is why this is such an important thing. If during your journey here, some of the diagnoses and things you were told you weren't overly aware, deeply understanding of, heaven forbid people without your background.
Exactly, Steve. This is why I've become such a passionate advocate, because even having a medical background, being able to read clinical papers, having a network in the healthcare system, I've got friends who are doctors. I was like, who's a good surgeon? Who's a good genetic? I found it overwhelming. And so I just really want to get that message out there to help other women try and navigate this whole process. It's really challenging and overwhelming. And I didn't even have cancer. Imagine how much harder it is to make these kind of decisions.
No, sorry, with we interjected there. You were just saying about your history and going through that process. Can you tell us a little bit more about that then?
Yes. So when another discussion with the surgeons, so in addition to whether I would have an MRI or not, was whether I should have genetic testing. So my mother's mum was diagnosed with ovarian cancer at age 90. So, mum was 59 with breast cancer. Her mum was 90 with ovarian cancer. No other breast or ovarian cancer in the family. So we thought the risk of me having a BRCA mutation was low, but, for me, knowledge is power. I wanted to know. So I did see a clinical geneticist and have genetic testing, which we both expected to be negative, but they found a CHEK2 mutation. And that's currently considered a moderate risk for breast cancer. I subsequently found out that came from my father's side. So it's quite confusing.
Yes.
I think I inherited my extremely dense breast from my mother and my mutation from my father.
Can I ask, was there significance around the age of 56? Sometimes people talk about their parents and when their parents get to that age. Did you find that a significant year or a significant age?
So when you look at the current kind of risk assessment guidelines for family history, it's under 50. That's the sort of the cutoff. So to meet the criteria for referral to a family cancer clinic, there's a lot of criteria, and most of them involve having relatives with cancer under the age of 50. So 56 is obviously over that, but it's still young.
Mm-hmm.
I'm 57 now. It's young.
Yeah,
I agree.
Yeah. Yeah. And from a personal perspective, managing one side with saying density of breast with an increased risk, and then the CHEK2 mutation, how did you process that information?
I found it very challenging to really understand what exactly the implications were. And I obsessively completed every risk assessment tool I could find. I entered different ages of menarche, different alcohol intakes, different BMIs to see if I could get different numbers. I think I was hoping I would magically find that I was not high risk. And that process on its own was confusing. For example, one tool gave me a lifetime risk of 45%. Another gave me a lifetime risk of 75%. In my mind, less than 50 doesn't seem so bad. But technically, depending on where you live, in Australia, high risk category is considered ×3 the population risk, which, what is that?
Yeah.
We think it's about 12% at the moment. If you live in the US, greater than 20% lifetime risk is considered high risk, and in the UK, greater than 30% is considered high risk. So whether I chose the lower or higher number, I was in the high risk category. So I was given 3 options: surveillance in the form of alternating MRI and mammograms in the hope of detecting cancer early. Choice number 2 was surveillance plus medication, tamoxifen, to reduce my risk. And then the third was risk-reducing surgery in the form of bilateral mastectomy. So I'm a believer in prevention is better than cure. I did not want to go through what my mother went through, so I had the surgery. Yeah. And I can honestly say it's such a relief to have the anxiety and worry of if and when I'm going to develop breast cancer removed. It's gone.
Thank you very much for sharing that. That's a very personal perspective going through. From the breast density side, you've done quite a bit of advocacy now. We have to thank you because you've actually sort of been the impetus for these podcasts. Can I ask about some of the factors that influence breast density?
Sure. So breast density relates to the amount of fibroglandular tissue in the breast, and it's influenced by hormonal factors such as estrogen exposure. So women tend to have less breast density after menopause, but if they take HRT, that can increase breast density. There's also an association of breastfeeding with breast density. So breastfeeding does tend to reduce breast density, but I couldn't tell you the extent of that. And women with a lower BMI tend to have higher breast density, and that may be a proportionate thing, the amount of fibroglandular tissue compared to the amount of fatty tissue. Very interestingly, despite generally appearing in the non-modifiable list of breast cancer risk factors, breast density is actually modifiable. Oh. And you remember I said one of my options was to take risk-reducing medication. So tamoxifen for premenopausal women and aromatase inhibitors for postmenopausal women are used as a strategy to decrease cancer risk. So traditionally, 20 doses of 20 milligrams of tamoxifen are used. That can cause some quite significant side effects, but studies from overseas show that even doses as low as 2.5 milligrams per day can decrease breast density by 20% and decrease breast cancer risk by 50%. It's significant.
Yes.
Yeah, tamoxifen is very underutilised as a risk-reducing strategy in Australia.
Now, there are some inconsistency about reporting breast density worldwide. From our perspective, it's not, I believe in Australia, it's not a reporting requirement at the moment being considered. What should general practitioners and patients know about breast density at the current time?
I'm very hopeful that breast density notification will occur in Australia. Very hopeful. I think there's overwhelming evidence now that it increases breast cancer risk. It reduces the sensitivity of mammograms. You can't see, it's hard to see cancer, which appears white on a mammogram on the background of white, dense tissue. So I think while we wait for that, GPs and women can start educating themselves on breast density, what it means. There is a lot of information out there. And if you look at BreastScreen South Australia website, where they've done the notification trials, there's some great videos, some great images, a lot of information. I think the real challenge is, what do we then do about it? What are the supplemental screening options or the imaging pathways for women? And that's a real challenge at this point in time. Again, there's a lot of evidence and information from overseas, but how that's going to roll out in Australia is a challenge. I think the other thing that we can do in the meantime is, look at that personalised risk assessment, which I think you'll be talking about.
Do you think it's going to become a standardised reporting item in the future?
I don't know whether there'll be standardised reporting in the same way that the FDA in the US has mandated. So they've will be requiring from September 2024 all mammogram facilities to include their wording for dense or not dense breasts. So rather than the 4 categories, they've grouped them into the 2, dense or not dense. I'm sure when your guest talks about the categories of breast density, they'll say that, the top 2, heterogeneously dense and extremely dense, are referred collectively as dense breasts. What I would like to see is women receive their own report with the images of the 4 categories and their personal density score, so they can see and understand where they sit.
Yes, that makes sense, because what you were saying before were just those 2 categories in the US reporting is too blunt a tool.
That's correct. And most of the studies on, supplemental screening are done in women with the extremely dense breast category. So that's in Australia, there's about 12% of women are in that extremely dense category.
For women who are high risk, what imaging, either pathways or additional modalities, are available?
Yeah, so again, this is a challenge in Australia. And the first challenge is determining whether or not they are at high risk. Most risk assessment that's done at the moment is based on family history. So a lot of women won't get additional assessment because they don't meet the criteria. But what we do know is that women with extremely dense breasts present the most significant risk after high-risk genetic mutations such as BRCA1 and BRCA2. And women with extremely dense breasts are 4 to 6 times more likely to have breast cancer. So I think once we start routinely measuring and reporting breast density, we'll be able to get better risk assessments and then better guidance on imaging pathways. In the meantime, women less than 60 who are classified as high risk, and the Medicare rebate criteria kind of list out those requirements. If they meet them, they will qualify for an MRI. So in fact, my second MRI that I had just before my surgery was funded by Medicare.
Now, you mentioned about your story, about you completing a whole bunch of personalised assessments and doing from, this one had a different result to this one. What should GPs know, or is there some reliable personalised assessments that patients can use for breast screening?
Yes, so Well, just first of all, overseas, there's an increasing move to start an initial assessment at age 25. So that will mostly be based on family history and will identify those at high genetic risk, but it also applies to women exposed to chest radiation at a young age. But then at a later stage, other factors come into play, like your estrogen exposure, breast density measurement, etc. At the moment in Australia, we have iPrevent, which is a validated risk assessment tool, and that's actually designed to be used as a discussion tool between GPs and women to discuss their risk, their screening options, and so on.
Just broadening things out as a final question, Sandy, are there any general things you'd love to say to GPs listening in? Any other thoughts or bits of advice for them?
I have lots. I think, GPs are so vital to our healthcare system. And, I would strongly encourage anyone to have a GP for life. So GPs, I think, can continue to encourage women to be breast aware. And I'd actually like to see that broadened beyond knowing the look and feel of your breast to what are the risk factors for breast cancer and what are your personal risk factors for breast cancer, because there's a lot, and a lot of them are underestimated, like breast density and alcohol. GPs can encourage women to complete iPrevent and then discuss that with them. GPs can encourage women to screen, and even though women aren't invited to breast screen until age 50, they can access it from age 40. I think GPs need to remember that women under 40 can and do get breast cancer. In fact, 3 women every day under 40 are diagnosed with breast cancer. So they need to take women seriously if they have concerns. I think GPs can start talking to women about breast density and what it means. If it's not reported by BreastScreen in their state, they can talk to women who may choose to pay, first step, pay for a mammogram. And my final message is that if you have heard that notifying women of their breast density will cause them undue anxiety or psychological harm, you can be completely reassured that the studies internationally and in Australia show that this is not the case. Women will continue to screen. And additionally, another study in South Australia showed that 80% of women want to know their breast density. It's time for them to know.
Dr. Sandy Minck, thank you for joining This Medical Life.
Thank you.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.